There is a moment that arrives quietly, often without warning. You are in the kitchen, preparing a meal you have made hundreds of times before, and suddenly you pause. You cannot remember whether you added the salt. You stand there, spoon in hand, and for a brief moment, the sequence eludes you. Or perhaps you are in a conversation, and a name you have known for decades simply will not surface. It is there, just beyond reach, and you wait for it to arrive. These moments pass. The salt is either in the dish or it is not. The name eventually comes, or someone supplies it. Life continues. But something lingers afterward, a quiet question that does not fully form but nonetheless takes up residence in the back of the mind. Was that normal? Is this how it begins? Should I be concerned? Most people never voice this question. They push it aside, attributing these moments to stress, to fatigue, to the simple fact of having lived many years. And often, they are right. But there is a deeper pattern beneath these experiences that is almost universally misunderstood. The distinction between the normal slowing of retrieval that comes with age and the functional changes that signal something more is not just a matter of degree. It is a matter of kind. And understanding this distinction changes everything about how we interpret what we observe in ourselves and in those we love. What follows is not a checklist of symptoms or a guide to self-diagnosis. It is an exploration of how the aging mind actually works, what changes, what remains stable, and when the difference between the two matters most. The answers may surprise you, not because they are dramatic, but because they are so consistently overlooked. You are listening to the Longevity Library, where we archive the wisdom of healthy aging, the architecture of a long life, understanding how we age and what shapes our later years. As we move through life, we begin to notice changes we did not experience before. A name that once came easily now lingers just out of reach. The stairs we took two at a time now demand our attention with each step. We wake in the morning and wonder whether the stiffness we feel is simply the body reminding us of its years or something that deserves closer attention. These moments are universal. They arrive for everyone who lives long enough to meet them. What is remarkable is how differently people experience these changes. Two individuals of the same age can have vastly different capacities, different levels of energy, different sharpness of mind. One person at 80 may still tend a garden, balance a checkbook without difficulty, and recall conversations from decades past with clarity. Another at the same age may struggle with basic tasks and find the world increasingly confusing. This variation has long fascinated those who study human aging, and in recent decades, researchers have begun to understand why these differences exist. The aging process is not simply a countdown from birth to a predetermined endpoint. It is influenced by a complex interplay of factors, some built into our biology, others shaped by how we live. Understanding these factors does not promise that we can stop the clock, but it does offer something perhaps more valuable: the knowledge that many aspects of how we age are not fixed. They respond to the choices we make, the environments we inhabit, and the habits we maintain over years and decades. This essay explores what we know about the aging process, particularly as it relates to the mind and the body's ability to function well into later life. It draws on observations from population studies, insights from cellular biology, and patterns that have emerged from watching how people live and age across different cultures and circumstances. The goal is not to provide a checklist of actions to take, but rather to build a coherent understanding of how aging works, and what that understanding might mean for those of us who hope to navigate our later years with clarity, capability, and a sense of continuity with the lives we have lived. Part 1. The landscape of aging. The difference between change and decline. One of the most important distinctions to make when thinking about aging is the difference between normal changes that come with time and the kinds of decline that signal something beyond the expected. This distinction matters because it shapes how we interpret what we observe in ourselves and in those we care about. Consider memory. Nearly everyone who lives into their 60s, 70s, or beyond will notice moments when recall is slower than it used to be. A familiar face appears, and the name attached to it does not arrive immediately. A word sits on the tip of the tongue, felt but not accessible. These experiences can be unsettling, particularly in a culture that prizes mental quickness. But research into how memory functions across the lifespan suggests that these moments are often not signs of a disease process. They are signs of a system that has accumulated a great deal of information over many decades. Think of the brain as a vast library. In youth, the library is relatively empty, so finding any particular book is quick and easy. By middle age, the shelves have filled. By later years, the library contains decades of accumulated knowledge, names, faces, facts, experiences, skills. Finding a specific piece of information in this crowded space takes longer simply because there is so much more to sort through. The book is still there. The retrieval process just requires more time. This slowing of retrieval is distinct from the kind of memory change that characterizes true cognitive decline. When someone forgets not just where they put their keys, but what keys are for, the nature of the problem is different. When a person who has prepared the same meal for 40 years suddenly cannot sequence the steps, something beyond normal aging is at work. The distinction lies in function. Normal aging may slow the system, but it does not break the connections between objects and their meanings, between actions and their purposes. The role of processing speed. Another universal change with age involves processing speed. The brain processes information more slowly in later years than it did in youth. This shows up in many ways: reacting to unexpected situations, learning new technology, following rapid conversation in noisy environments. The information eventually arrives and is understood, but the pathway takes longer. This slowing has a physical basis. The brain's white matter, which contains the fibers that connect different regions, undergoes changes over time. The insulation around these fibers, called myelin, may degrade slightly. The connections themselves may become less numerous. The result is that signals traveling from one part of the brain to another do so with less speed and efficiency than they once did. This is not a disease. It is a characteristic of an aging nervous system. And importantly, the brain compensates for these changes in ways that are not always apparent. Experience and accumulated knowledge allow older individuals to solve problems using different pathways than a younger person might use. The same information is accessed, just through a different route. Hormones and their influence. The body's chemical signaling systems also change with age, and these changes can affect how the mind functions. For women, the transition through menopause brings significant shifts in estrogen and progesterone. These hormones have effects throughout the body, including the brain. Some women notice increased forgetfulness during this time, moments of mental fuzziness that were not present before. Research suggests this is related to the hormonal fluctuations themselves. And for many women, these cognitive symptoms stabilize once hormone levels settle into their new pattern. For men, testosterone declines gradually over decades. This hormone also influences cognitive function, particularly aspects of spatial reasoning and verbal memory. The decline is slow enough that many men do not notice its effects, but studies have found associations between lower testosterone levels and certain cognitive changes in older age. It is worth noting that these hormonal influences exist on a spectrum. They interact with other aspects of health and with the natural variations in how individuals respond to hormonal change. Some people notice significant effects, others notice little to nothing. Both experiences fall within the range of normal. Part 2. when memory changes signal something more. Understanding functional impairment. The boundary between normal age-related change and a condition that requires medical attention is often marked by function. When memory or thinking difficulties begin to interfere with a person's ability to carry out their usual activities, that is when concern is warranted. This concept of functional impairment is central to how clinicians think about cognitive disorders. A person might have some memory difficulty, but if they can still manage their finances, prepare their meals, take their medications correctly, and navigate their environment safely, the changes may not rise to the level of a clinical problem. When those abilities begin to slip, when bills go unpaid, when meals are burned or forgotten, when getting lost in familiar places becomes common, then the situation has changed. The kinds of tasks that matter for this assessment are those that require multiple steps and sustained attention. Making a sandwich seems simple, but it involves planning, sequencing, remembering ingredients, and executing each step in order. Driving requires constant processing of visual information, decision-making, and the ability to react to unexpected situations. Managing medications involves understanding schedules, recognizing different pills, and remembering whether a dose has been taken. When these activities become difficult, it suggests that the cognitive systems supporting them are not functioning as they should. The many routes to cognitive decline. Not all cognitive decline follows the same path, and not all of it is caused by the same underlying processes. Understanding this diversity is important because different causes may respond to different approaches. Some cognitive problems stem from structural issues in the brain. A stroke, for example, occurs when blood supply to part of the brain is interrupted. The affected tissue may die, and the functions that tissue supported may be impaired. If strokes are small and accumulate over time, the resulting cognitive changes can be gradual, sometimes mistaken for a different kind of decline. This is sometimes called vascular cognitive impairment, and it is one of the more common forms of cognitive difficulty in older adults. Head trauma is another structural cause. A significant injury to the brain can have immediate effects on cognition, and repeated injuries over time can lead to cumulative damage. This has been observed most dramatically in athletes who experience repeated concussions, but it can also occur in anyone who has had serious falls or accidents. Hydrocephalus, a condition where cerebrospinal fluid accumulates and puts pressure on the brain, can also affect cognition. This condition sometimes produces a recognizable pattern of symptoms that includes difficulty walking, urinary incontinence, and cognitive changes. When identified, it can often be treated by draining the excess fluid, sometimes leading to significant improvement. Beyond these structural causes, metabolic and physiologic factors can play a role. Poorly controlled diabetes affects blood vessels throughout the body, including those in the brain. Over time, this can contribute to cognitive difficulties. Thyroid disorders, vitamin deficiencies, and other metabolic abnormalities can also affect brain function. And when these are identified and corrected, cognitive symptoms sometimes improve. Sleep disorders deserve particular attention. Obstructive sleep apnea, a condition where breathing repeatedly stops during sleep, has been linked to cognitive problems. The reasons are straightforward. When breathing stops, oxygen levels drop, and the brain is deprived of the oxygen it needs. Additionally, the frequent awakenings that occur with sleep apnea prevent the brain from getting the deep, restorative sleep that supports memory and cognitive function. Treating sleep apnea, often with a device that keeps the airway open during sleep, can lead to noticeable improvements in daytime thinking and energy. The degenerative dementias, a separate category of cognitive decline, involves progressive degeneration of brain tissue. These conditions, which include Alzheimer's disease and other dementias, are characterized by the gradual accumulation of abnormal proteins in the brain and the eventual death of brain cells. For many years, these conditions could only be diagnosed by observing symptoms over time and ruling out other possible causes. A diagnosis of Alzheimer's was essentially a diagnosis of exclusion, if everything else was ruled out and the symptoms followed a certain pattern. Alzheimer's was presumed to be the cause. This approach left considerable uncertainty. Patients and families often wondered whether the diagnosis was correct, and clinicians had limited ability to provide definitive answers. That has changed in recent years. Advances in understanding the biology of Alzheimer's have led to the development of tests that can detect its characteristic features in living people. These tests represent a fundamental shift in how the disease is diagnosed, from a process of ruling out other conditions to one of ruling in Alzheimer's specifically. Part 3. The new landscape of Alzheimer's diagnosis. What happens in the Alzheimer's brain? To understand the diagnostic tests now available, it helps to understand what researchers have learned about what happens in the brain as Alzheimer's develops. Two proteins are central to the process. The first is beta-amyloid. This protein fragment accumulates in the spaces between nerve cells, forming clumps called plaques. These plaques interfere with communication between neurons and trigger inflammatory responses that can damage cells. The accumulation of amyloid is thought to begin many years before symptoms appear, slowly building up until it reaches a threshold where damage becomes apparent. The second protein is tau. Inside nerve cells, tau protein normally helps maintain structures called microtubules that transport nutrients and other materials within the cell. In Alzheimer's disease, tau becomes abnormal and forms tangles inside cells. These tangles disrupt the transport system and eventually contribute to cell death. The relationship between amyloid and tau is complex, but the presence of both in characteristic patterns is now understood to be the biological signature of Alzheimer's disease. Detecting these proteins in a living person provides strong evidence that Alzheimer's is present. Spinal fluid analysis. One way to detect these proteins is through analysis of cerebrospinal fluid, the clear fluid that bathes the brain and spinal cord. This fluid can be sampled through a procedure called a lumbar puncture, often referred to as a spinal tap. The procedure involves inserting a thin needle between the vertebrae in the lower back to access the space around the spinal cord. A small amount of fluid is withdrawn and sent to a laboratory for analysis. The fluid is tested for levels of beta-amyloid and tau proteins. In Alzheimer's disease, a characteristic pattern emerges. Levels of a specific form of amyloid, A-beta-42, are typically low, while levels of tau and phosphorylated tau are elevated. This pattern reflects what is happening in the brain. Amyloid that should be in the fluid is instead trapped in plaques, so fluid levels are low. Tau, released from dying neurons, appears in higher concentrations. The combination provides a biochemical snapshot of the disease process. For many people, the idea of a spinal tap brings to mind images of painful procedures and prolonged recovery. In practice, the procedure has evolved considerably. Very thin needles are used. The area is numbed, and the actual sampling takes only a few minutes. Patients typically lie flat for an hour or so afterward to reduce the chance of headache, and then resume normal activities. The entire process is often done in a clinic or doctor's office without requiring a hospital stay. The results from spinal fluid analysis are highly accurate, with studies suggesting around 90% sensitivity and specificity for detecting Alzheimer's pathology. This means that when the characteristic pattern is present, it is very likely that Alzheimer's is the cause of cognitive symptoms. Amyloid PET imaging. For individuals who cannot undergo a spinal tap, whether due to blood-thinning medications that increase bleeding risk, anatomical factors that make the procedure difficult, or personal preference, another option exists. Amyloid PET imaging uses a specialized radioactive tracer that binds to amyloid plaques in the brain. The procedure involves injecting a small amount of the tracer into a vein. The tracer circulates through the bloodstream and crosses into the brain, where it attaches to amyloid plaques. The patient then lies in a PET scanner, which detects the signal from the tracer and creates images showing where amyloid has accumulated. These images provide a visual map of amyloid burden in the brain. Areas with significant plaques show up clearly, allowing clinicians to see whether the pattern is consistent with Alzheimer's disease. Like spinal fluid analysis, amyloid PET imaging has high accuracy, with studies suggesting approximately 95% sensitivity and specificity. The availability of these tests has transformed the diagnostic process. Where once patients and families had to live with uncertainty, they can now receive a definitive answer. This matters not only for peace of mind, but for treatment planning, as the approach to managing symptoms may differ depending on the underlying cause. Part 4. The concept of windows in disease progression. Understanding the stages. One of the most important insights to emerge from studying Alzheimer's disease is an understanding of how it progresses over time. The disease does not move at a constant rate, nor does it affect all functions simultaneously. Instead, it tends to progress through recognizable stages, and each stage has its own duration. In the mild stage, symptoms are noticeable but do not completely disable the person. There may be difficulty remembering recent events, trouble finding words, or challenges with complex tasks like managing finances or following detailed instructions. The person can still perform most daily activities independently, but may need more time or occasional help. The moderate stage brings more significant changes. Independence diminishes. The person may need help with activities like dressing, bathing, and preparing meals. Confusion about time and place becomes more common. Behavioral changes may emerge: irritability, suspicion, or agitation. Communication becomes more difficult. The severe stage involves profound impairment. The person may lose the ability to speak coherently, recognize loved ones, or control movement. Round-the-clock care is typically necessary, and the body becomes increasingly vulnerable to other health problems. Research suggests that each of these stages lasts approximately 2 years. A person may spend about 2 years in the mild stage before progressing to moderate, and another 2 years in the moderate stage before reaching severe. The severe stage can last for several years. The implications for intervention. This 2-year window in each stage has important implications for treatment. Interventions that aim to slow the disease process are likely to be most effective when started early, before extensive damage has occurred. In the mild stage, more brain function remains intact, and there is more to preserve. If a person has been experiencing symptoms for a year and is in the mild stage, they may have approximately 1 year left before transitioning to moderate decline. Starting treatment during that year offers the opportunity to potentially extend the mild stage or slow the progression of symptoms. This is why delays in diagnosis matter. Every month spent wondering whether symptoms are significant, every appointment postponed, every evaluation delayed is time lost from that window. For individuals and families facing a progressive condition, time is not an abstract concept. It translates directly into preserved function, maintained independence, and quality of life. Part 5. Treatment approaches in the current era. Disease-modifying therapies. In recent years, the first medications designed to modify the underlying disease process in Alzheimer's have become available. These are not treatments that temporarily boost cognition or manage symptoms. They aim to intervene in the biological process itself, specifically by reducing the burden of amyloid plaques in the brain. These medications are monoclonal antibodies, laboratory-designed proteins that act like the body's own antibodies. They bind to amyloid and help the immune system clear it from the brain. The goal is to reduce the plaque burden that characterizes Alzheimer's, thereby slowing the progression of symptoms. Clinical trials of these medications have shown that they do reduce amyloid levels in the brain. The degree of clinical benefit, how much they slow cognitive decline, has been the subject of discussion and ongoing research. What is clear is that these medications represent a new category of treatment, one that targets the disease process itself rather than just its symptoms. Who may be appropriate for treatment? These medications are most appropriate for individuals in the mild stages of Alzheimer's disease. The official labeling may say they are for Alzheimer's generally, but the evidence supporting their use is strongest for those with mild cognitive impairment or mild dementia. This again reinforces the importance of early diagnosis. By the time someone has reached the moderate stage, the opportunity for maximum benefit may have passed. The decision to pursue treatment involves multiple considerations. The medications are administered by intravenous infusion, typically every few weeks. This requires regular visits to an infusion center. There are potential side effects, including a condition called amyloid-related imaging abnormalities, which involves temporary swelling or small bleeds in the brain. These are often asymptomatic and resolve on their own, but they require monitoring through regular MRI scans. For many individuals and families, the possibility of slowing disease progression outweighs the burdens of treatment. For others, the commitment may not feel appropriate. These are personal decisions that should be made in consultation with knowledgeable clinicians who can explain the expected benefits and potential risks. The pipeline of new medications. The medications currently available are likely to be joined by others in the near future. Several pharmaceutical companies have similar drugs in late-stage clinical trials. These target the same amyloid pathway but may have different dosing schedules, different side effect profiles, or different levels of efficacy. The next few years are expected to bring additional approvals, expanding the options available to patients. This is a rapidly evolving area of medicine, and what is available today may be only the beginning of a broader shift toward biologically targeted treatments for neurodegenerative conditions. Part 6. The connection between body and mind. Physical health and cognitive function. The brain does not exist in isolation. It is part of a body, and its health is influenced by the health of every other system. This connection between physical health and cognitive function is one of the most robust findings in aging research. Cardiovascular health is particularly important. The brain requires a constant supply of oxygen and nutrients, delivered through an extensive network of blood vessels. Conditions that damage blood vessels, high blood pressure, diabetes, high cholesterol, also affect the brain. Over time, this damage can contribute to cognitive decline. This is why managing cardiovascular risk factors is often discussed in the context of brain health. Keeping blood pressure within a healthy range, controlling blood sugar, and maintaining healthy cholesterol levels all support the vascular system that nourishes the brain. These are not treatments for dementia, but they are strategies for maintaining the conditions in which the brain can function well. Physical activity also plays a role. Exercise increases blood flow throughout the body, including the brain. It supports the health of blood vessels and may promote the release of factors that support the growth and survival of neurons. Studies have found associations between regular physical activity and lower rates of cognitive decline, though the exact mechanisms continue to be studied. Metabolic health. The body's metabolic state, how it processes and uses energy, also affects the brain. Diabetes, as mentioned, damages blood vessels. But even before diabetes develops, insulin resistance can affect brain function. Insulin receptors are present throughout the brain, and insulin signaling plays a role in memory formation. when the body becomes resistant to insulin. This signaling may be disrupted. Thyroid function is another metabolic factor. Thyroid hormones regulate the rate at which cells use energy, and both too little and too much thyroid hormone can affect cognition. Thyroid disorders become more common with age and are often treatable, making them an important consideration in any evaluation of cognitive symptoms. Nutritional status matters as well. Deficiencies in certain vitamins, particularly B12, which is involved in maintaining nerve health, can produce cognitive symptoms that mimic dementia. These deficiencies are more common in older adults due to changes in absorption and sometimes due to dietary patterns. Identifying and correcting them can lead to improvement. Sleep and brain health. The relationship between sleep and cognition deserves special attention. During sleep, the brain performs essential maintenance functions. It consolidates memories, clearing away the day's experiences and storing important information for the long term. It also clears waste products that accumulate during waking hours. The glymphatic system, a recently discovered waste clearance pathway in the brain, is most active during sleep. When sleep is disrupted, these processes are impaired. Chronic sleep deprivation affects attention, memory, and executive function. Over time, poor sleep may contribute to the accumulation of the very proteins involved in Alzheimer's disease. Some studies have found associations between sleep disturbances and higher levels of amyloid in the brain. Obstructive sleep apnea is particularly relevant because it is common and treatable. The repeated drops in oxygen that occur with apnea stress the brain and disrupt sleep architecture. Treating apnea often leads to improvements in daytime alertness and cognitive function, sometimes dramatically. Part 7. The social brain. The importance of connection. Humans are social creatures, and the brain has evolved to function in a social context. Throughout life, social interaction provides stimulation, emotional support, and opportunities for learning and engagement. In later years, maintaining social connections may be as important for brain health as any other factor. Research has found associations between social engagement and cognitive function in older adults. People who maintain active social lives, who participate in community activities, who regularly interact with family and friends, tend to have better cognitive outcomes than those who are isolated. The reasons are likely multiple. Social interaction provides mental stimulation, conversation requires attention, memory, and language skills. It provides emotional support, which buffers against stress. It encourages participation in other activities that are good for the brain, like going out, exercising, and trying new things. Conversely, social isolation has been linked to cognitive decline. The mechanisms are not fully understood, but isolation may reduce cognitive stimulation, increase stress, and decrease motivation to engage in healthy behaviors. It may also be associated with depression, which itself can affect cognitive function. The impact of major disruptions. The COVID-19 pandemic provided a natural experiment in the effects of social isolation for many older adults, particularly those in nursing homes or other congregate settings. The lockdowns meant sudden and prolonged separation from family and normal social activities. Clinicians observed noticeable declines in some patients during this period, accelerated cognitive deterioration that seemed linked to the isolation itself. This observation underscores something important about the nature of cognitive health. The brain thrives on engagement. When that engagement is removed, even temporarily, the effects can be significant. For individuals already coping with cognitive challenges, the loss of familiar faces, routines, and stimulating interactions may hasten decline. As society has emerged from the pandemic, re-engagement has become a priority. For older adults who have been isolated, gradually returning to social activities, reconnecting with family and friends, and participating in community life can support cognitive health. This does not mean that socialization is a treatment for dementia, but it is an important component of overall well-being. Purpose and meaning. Beyond social connection, having a sense of purpose, a reason to get up in the morning, has been associated with better health outcomes in older adults. People who feel their lives have meaning, who have goals they are working toward, who feel needed and valued, tend to fare better than those who do not. This sense of purpose can come from many sources. It might come from family, caring for grandchildren, staying connected with children. It might come from community, volunteering, participating in religious or civic organizations. It might come from personal projects, gardening, writing, creating art, learning new skills. It might come from work, paid or unpaid, that provides structure and meaning. The common thread is engagement with life. The brain that is engaged, that has reasons to pay attention and remember and plan, is a brain that is being used. And like any other organ, the brain benefits from use. Part 8. Patterns of healthy aging across populations. Observations from long-lived communities. Researchers have long been interested in communities around the world where people live unusually long. Healthy lives. These have been studied in places like Okinawa in Japan, Sardinia in Italy, Ikaria in Greece, and among Seventh-day Adventists in Loma Linda, California. While these communities differ in many ways, certain patterns recur. Diet is one common factor. In these communities, people tend to eat mostly plant-based foods, vegetables, legumes, whole grains. Meat is consumed, but in smaller amounts than in typical Western diets. Processed foods are minimal. Meals are often social occasions, eaten with family and friends. Physical activity is another common factor. People in these communities do not necessarily go to gyms or follow exercise routines. They live active lives, walking, gardening, doing physical work. Activity is woven into daily life rather than being a separate activity to be scheduled. Social connection is consistently present. These communities tend to be cohesive. People know their neighbors. Family ties are strong. Older adults remain integrated into community life, not segregated from it. They have roles and responsibilities, things to do, and people who depend on them. Purpose and spirituality also appear. Many of these communities have strong religious or spiritual traditions. People have frameworks for understanding their lives and their place in the world. They have practices, prayer, meditation, community rituals that provide structure and meaning. What these observations suggest: the patterns observed in long-lived communities do not prove that any single factor causes longevity. These are observational findings, not controlled experiments. But they do suggest that healthy aging is not just about avoiding disease. It is about how life is structured, what people eat, how they move, how they connect with others, what gives their lives meaning. These observations also suggest that the way we live in modern societies may work against healthy aging. Processed foods, sedentary lifestyles, social fragmentation, and loss of purpose are not features of the communities where people live longest. They are features of the environments many of us inhabit. This does not mean we must replicate the exact conditions of Okinawa or Sardinia to age well. But it does suggest that paying attention to these domains, nutrition, activity, connection, purpose, may support healthier aging, regardless of where we live. Part 9. The environment we create. The physical environment. Where and how we live affects how we age. The physical environment can either support or undermine our ability to maintain function and independence. Consider the simple matter of walking. If we live in a place where walking is pleasant and safe, where there are sidewalks, crosswalks, places to walk to, we are more likely to walk. If we live in a place where walking feels hazardous or where there is nowhere to go, we are less likely to walk. Over years, this difference accumulates. Consider social connection. If we live in a community where we know our neighbors, where there are places to gather, where activities are available, we are more likely to stay socially engaged. If we live in isolation, separated from others by distance or design, engagement becomes harder. Consider access to healthy food. If we live near markets that sell fresh produce, if we have transportation to reach them, if we can afford to buy what is there, we are more likely to eat well. If we live in a food desert, where only processed options are available, eating well requires much more effort. These environmental factors are not under individual control in any simple way. They are shaped by where we have chosen or been able to live, by community resources, by transportation systems, by economic circumstances. But recognizing their influence can help us think about what modifications might be possible and can inform how we support others whose environments may not be optimal. The information environment. We also live in an information environment that affects how we think about aging. The messages we receive from media, from advertising, from the culture around us, shape our expectations and beliefs. Some of these messages are unhelpful. Aging is often portrayed as a time of inevitable decline, of loss, of becoming a burden. These portrayals can become self-fulfilling prophecies. If we expect to decline, we may be less motivated to engage in behaviors that would maintain function. If we expect to become dependent, we may surrender independence prematurely. Other messages are unhelpful in a different way. The promise of anti-aging miracles, of supplements or treatments that will stop or reverse aging, sets up false expectations. Aging is a biological process, not a disease to be cured. No pill, no potion, no procedure will make a 60-year-old body function like a 20-year-old body. The goal is not to defeat aging, but to age well, to maintain function, to preserve what matters, to live fully within the capabilities of our years. A more helpful message is that aging is variable, that many aspects of how we age are influenced by how we live, and that it is never too late to make changes that support health. This is not a promise of miracle, but an invitation to engagement. Part 10. Integration. How the pieces fit together. The interconnected nature of health. Throughout this discussion, we have touched on many factors that influence how we age, the distinction between normal change and disease, the biological processes underlying cognitive decline, the diagnostic tools now available, the treatments that exist, the lifestyle factors that support brain health, the social and environmental contexts in which we live. These are not separate domains. They are interconnected. Physical health affects cognitive health. Social connection affects both. Environment shapes behavior. Purpose influences motivation. The body and mind are not separate systems. They are aspects of a single organism. This interconnectedness has practical implications. Improving one area often has ripple effects. Becoming more physically active may lead to better sleep, which supports cognitive function, which makes social engagement easier, which provides motivation to stay active. Conversely, decline in one area can cascade. Poor sleep affects mood, which reduces motivation to socialize, which decreases physical activity, which further disrupts sleep. The concept of reserve. One way researchers think about these interconnections is through the concept of reserve. Reserve refers to the brain's ability to cope with damage or decline. Two people with the same amount of brain pathology may have very different functional outcomes. The person with greater reserve, whether built through education, complex occupations, physical activity, or social engagement, may maintain function longer. Reserve is not a fixed quantity. It can be built throughout life. Education in early life contributes to reserve. So does engaging work in midlife. So does staying mentally, physically, and socially active in later life. Every time we learn something new, every time we challenge ourselves, every time we connect with others, we may be adding to our reserve. This does not mean that reserve can completely protect against diseases like Alzheimer's, but it may influence how long a person can function well despite the presence of disease. It may extend the period of independence and quality of life. The time horizon. Another way to integrate these ideas is to consider time. The choices we make today do not just affect how we feel tomorrow. They affect our trajectory over years and decades. The patterns we establish, how we eat, how we move, how we connect with others, how we engage with the world, accumulate. They shape the path we travel as we age. This is both sobering and encouraging. It is sobering because it means that neglect has cumulative effects. Years of poor diet, inactivity, and isolation do not suddenly become problems at age 70. They have been building toward that moment all along. But it is encouraging because it means that positive changes also accumulate. Starting to walk regularly at age 60, reconnecting with old friends at 65, taking up a new hobby at 70, these are not pointless gestures. They are investments in future function. They may not reverse all the effects of previous decades, but they shift the trajectory in a positive direction. Part 11. Navigating the healthcare system. When to seek evaluation. Given what we know about the windows of opportunity in progressive conditions, the question of when to seek evaluation becomes important. The answer is not simple, because the line between normal aging and concerning change is not always clear. But certain patterns suggest that evaluation is warranted. When memory or thinking difficulties begin to interfere with daily life, that is a signal. When a person who has always managed their finances starts making errors or missing payments. When a person who has always cooked gets confused about familiar recipes. When a person who has always driven safely gets lost on familiar routes. When family members express concern about changes they have observed. Another signal is when changes happen relatively quickly. Normal aging is gradual. If someone who was functioning well 6 months ago is now struggling noticeably, that faster pace warrants attention. A third signal is when the person themselves is concerned. Sometimes individuals sense that something is wrong even when they cannot articulate exactly what. That internal sense of change is worth respecting. What an evaluation involves. A thorough evaluation for cognitive concerns typically involves several components. The first is a detailed history, talking with the person and with family members about what changes have been noticed, when they started, how they have progressed. This history provides context that no test can replace. Cognitive testing follows. This may be a brief screening test in a primary care setting or more comprehensive testing by a specialist. The tests assess different domains: memory, attention, language, visuospatial skills, executive function. They provide objective information about how a person performs compared to others of similar age and education. Laboratory tests are usually done to check for metabolic causes of cognitive symptoms, thyroid disorders, vitamin deficiencies, signs of infection or inflammation. These are treatable conditions that might otherwise be missed. Brain imaging, typically MRI, looks for structural causes, strokes, tumors, evidence of hydrocephalus, patterns of atrophy that might suggest specific conditions. The images provide a view of the brain structure that complements the functional information from cognitive testing. Depending on the results of these initial steps, more specialized testing may be recommended. This could include the spinal fluid analysis or amyloid PET imaging discussed earlier, which can provide definitive information about whether Alzheimer's pathology is present. The role of specialists. Primary care physicians play an important role in initial evaluation and in identifying when specialist referral is appropriate. neurologists, geriatricians, and geriatric psychiatrists have additional training in cognitive disorders and access to specialized diagnostic tools. Neuropsychologists can provide detailed cognitive testing that helps characterize the nature and severity of difficulties. For most people, the pathway involves starting with a primary care provider, then moving to a specialist if the situation warrants. The key is to start, to bring concerns forward rather than waiting to see if they resolve on their own. Part 12. Living with knowledge. The value of clarity. For much of human history, cognitive decline in later years was simply accepted as part of aging. There were no names for different types of dementia, no ways to know what was happening inside the brain, no treatments to consider. Families coped as best they could with uncertainty layered on top of difficulty. That is no longer the situation. We now have the ability to know, with considerable accuracy, what is happening when cognitive symptoms appear. We can distinguish normal aging from disease. We can identify specific disease processes. We can, in some cases, intervene with treatments that target those processes. This knowledge is valuable even when it does not lead to treatment. Knowing what one is facing allows for planning. It allows families to have honest conversations about the future. It allows for decisions about legal and financial matters while the person can still participate. It allows for realistic expectations rather than hope mixed with fear. For some, the knowledge brings relief. The uncertainty of not knowing, wondering whether symptoms are serious, whether they will progress, what the future holds, can be as distressing as the symptoms themselves. A definitive diagnosis, even of a serious condition, can be easier to bear than endless uncertainty. The limits of knowledge. At the same time, it is important to acknowledge what knowledge cannot do. A diagnosis is not a prediction of exactly how an individual will fare. People with the same diagnosis can have very different trajectories. Some decline slowly, maintaining function for many years. Others decline more quickly. The averages we discuss, the 2-year windows in each stage, are just that. Averages. They describe populations, not individuals. Knowledge also cannot erase the emotional reality of facing a progressive condition. For the person experiencing symptoms, there may be grief, fear, frustration. For family members, there may be anticipatory grief, worry about the future, the stress of caregiving. These emotions are real and valid. They are not resolved by diagnosis, though they may be informed by it. The goal of knowledge is not to eliminate these human responses. It is to provide a foundation for facing them, to replace confusion with clarity, to allow for informed decisions, to point toward available supports and resources. The continuity of self. One concern that often arises when discussing cognitive decline is the fear of losing oneself, of becoming a different person, of no longer being who one has been. This fear is understandable, but it may be oversimplified. Even in progressive conditions, the self does not disappear all at once. There are good days and bad days. There are moments of clarity and connection. There are aspects of personality that persist long after memory has faded. The person who was kind remains kind. The person who loved music still responds to music. The person who found joy in simple pleasures can still find joy. This continuity is worth honoring. It means that even as abilities change, the essential person remains. Relationships can continue, adapted to new circumstances. Connection can be maintained through touch, through music, through familiar routines, through simply being present. For families, this understanding can shift the focus from what has been lost to what remains. It can open up new ways of connecting that do not depend on memory or complex conversation. It can allow for continued relationship even as the nature of that relationship changes. Part 13. Looking forward. The pace of change. The field of dementia research is moving quickly. What was unknown 20 years ago is now understood. What was impossible 10 years ago is now routine. What is experimental today may be standard practice in 5 years. This pace of change means that the information available now may not be the final word. New diagnostic tools will likely emerge. New treatments will likely be approved. New understanding of risk. The single most important idea to carry forward is this. The difference between the changes we must accept and the changes we can address is not always obvious, but it is knowable. The tools now exist to replace uncertainty with clarity. And that clarity, however difficult it may sometimes be, is itself a form of empowerment. It allows for planning, for connection, for making the most of whatever time and capacity remain. If this discussion has prompted thoughts or reflections about your own experiences, or about someone you care for, we invite you to share them in the comments. Not because there are simple answers, but because the conversation itself matters. And if you would like to continue exploring the many dimensions of healthy aging, we hope you will visit the other videos in this library. Each one is an invitation to understand a little more deeply what it means to live well across all the years we are given. This is the Longevity Library. Listen, learn, and live longer.